All right. Well, I have 8:03, so I think we should get started. Well, welcome everyone. Thank you for starting your second Wednesday of the month with us at the Business Education Compact. My name is Mari Sell. I'm the Executive Director of the Alaska Workforce Alliance. We're a subsidiary of the Alaska Safety Alliance, and I'm joined today with several of my colleagues here. We've got Taylor Cronin Segura on. I see Jacqueline Summers on, and maybe we've got a few more ASA or AWA folks that I can't see, but welcome everyone. The purpose of our group, the purpose of the Business Education Compact is to bring together industry members, education community, training community, economic development community, so we can talk about the shared problems that we have and the shared priorities that we have related to workforce development in Alaska. And Mr. Dave Reese, who's on our call, he is the father of the Business Education Compact. He started this group back in 1989, so that industry and the education community have a forum and a place to get together to have these kinds of conversations. So today's topic is building a resilient workforce featuring traumatic brain injury experts, Dr. Adam Gove and Dr. Audra Yewchin. And we are also speaking about access to mental health featuring Dr. Eric Arzubi with Frontier Psychiatry. But before we get started, we have some housekeeping notes here. As I mentioned earlier, if you would click on your participants link, add your name and organization so we can see who you are and where you're coming from. That would be really helpful to us. If you have an idea for an upcoming BEC meeting, please email Taylor, Taylor at alaskaworkforcealliance.org. Also, if you're not receiving notices about our BEC meetings, please sign up on our website to join the BEC list so you can get these reminders. Our meetings are the second Wednesday of every month, and they are recorded, and you can access that recording from our BEC page on our website. And it's listed here. You can always just email Taylor if you need to find it. Please remember that we are taking a recess in July, so take that off your calendars. No BEC meeting in July. We are meeting next month, and the topic will be opportunities in the construction sector, featuring ICER, the Institution for Socioeconomic Research, which is a part of the University of Alaska, and the Alaska General Contractors Association. All right. We also want to highlight this. Oh, it says April. Sorry, this is May. We want to highlight the May issue of Alaska Economic Trends. This publication comes out every month. It's really quite outstanding. And this month's issue focuses on what's happening out in the Mat-Su Valley. The Mat-Su is one of Alaska's fastest growing regional economy. Their population growth has far outpaced Anchorage and outpaced most of the state in terms of their rate of growth. And this month's Trends magazine highlights why, featuring affordability of their land and new housing construction, and just how that community is changing and how that impacts our workforce. So check it out, and you can sign up to have that get delivered directly to your inbox every month, and I would encourage you to do that. All right. So we ask for a mission moment. So a mission moment is a reflection, a story, or some kind of outcome that connects to our purpose and impact. Does anybody have a mission moment for us? Jacqueline.
I have one, Mari. Well, I had the great pleasure of going to the Alaska HOSA conference at the early part of April. And if you don't know about HOSA, it is a national program that introduces middle school and high school students to healthcare careers. And it was truly inspiring. It was a 2-day conference. It featured students from all over Alaska, and they had to go through all kinds of tests. Actually, they had to show what they had learned. So I was able to be a judge in one of the areas, and the students had to pretend to be taking a poison control call and tell the mom what to do. Or the other thing that they had to do during this is they had to welcome a new mom with a new baby and tell the mom what the measurements and other statistics were. And so it was the kids were on fire. They have to show up. They have to be dressed very formally. It's very professional, and they get to connect with Alaskan healthcare providers. I just encourage you to attend that or support it. And it was truly, it really brought me home as to why we do this work. And it was wonderful to be around all that energy.
Thanks, Jacqueline. That's really inspiring. I've been to HOSA conferences in past years, and you really walk away feeling like the future is in excellent hands. So thanks for sharing that. Anybody else have a mission moment they'd like to share? If not, we'll move on. Okay. All right. So without further ado, I would like to introduce Dr. Adam Grove and Audra Yewchin. So I am going to spotlight the two of you. Taylor, can you make sure that both of our speakers are highlighted? Dr. Adam Grove is a naturopathic doctor based in Anchorage, specializing in children and adults with traumatic brain injury. Dr. Grove received his doctorate from Bastyr University in Seattle, Washington in 2002. He holds a Master of Arts degree in Soviet Area Studies from the Naval Postgraduate School and a Bachelor of Science degree in Aerospace Engineering. He is a member of the American Association of Naturopathic Physicians, member of the Alaska Brain Injury Council, founder of the Alaska Brain Injury Consortium and Alaska Brain Bus Project, and a certified brain injury specialist. Audra Yewchin, Doctor of Occupational Therapy, occupational therapist registered and licensed, is a lifelong Alaskan and owner of Outstanding Therapy Solutions, LLC, specializing in neurological and visual rehabilitation with a focus on return to work planning and functional independence after brain injury. She partners with the Alaska Division of Vocational Rehabilitation to conduct functional capacity evaluations that guide career decisions and serves as a hub team member for the UAA Center for Human Development's ECHO for Brain Injury Initiative, contributing to statewide outreach, including rural communities. Drawing on both clinical expertise and personal connection to the disability community, she develops practical, sustainable solutions that support workforce retention and long-term recovery. With that, I will pass it over to these two speakers to share their screen and begin their presentation. Hey, Dr. Grove, I think you're still on mute.
Yeah, I make that mistake all the time, right? So just amazing. It makes us sound so fancy, right? So yes, so thank you. That was a great introduction and a sort of a good overview of where Dr. Yewchin and I are trying to go with this, because I think, and once the slides come up here, we'll jump into that. But the important thing is the impact of brain injuries, which some of you have maybe not heard of per se. You've heard the word concussion, and a lot of people are familiar with that term. But a concussion really is a brain injury, which sounds much more serious. And in fact, they are quite serious. And Dr. Yewchin and I are working on trying to not only educate people about that, but to find some solutions, because brain injuries have a huge impact, as we'll see, on Alaska's workforce. And so thank you for letting us be here. And I'm really interested also to hear what Dr. Arzubi has to say after this. So I think we've got a great presentation here because they tie together, right? So let's just jump in here, and we'll start by just, oops, finding the right slide. Okay, so Dr. Audra Yewchin and I started working together. Well, we've worked together for many years, on and off. So we actually just came together we both started nonprofits on our own as a way to come up with some solutions for Alaska. And we kind of did this independently. We worked together under another nonprofit years ago, and we kind of went our separate ways, started our own nonprofits, and we kind of came back together. So I kind of love the way the universe does things, right? So, and here's just a list of some of the things that the Brain Injury Consortium is doing. And Audra, I don't know if you want to say a few words about Real Solutions.
Basically, we are working toward establishing more long-term treatment and focused kind of intensive treatment programs for people with brain injury and also other recovery. So yes, returning to work, but creative solutions as far as allowing people who are highly functional but maybe a little bit disconnected after brain injury or another injury to have a place where they can come and have a little bit of support to engage with community activities or favorite activities, whether it's recreation or theater or music or that sort of thing. So that's our mission and our goal here.
And I think, Audra and I both came to this with the same goal, right? We see patients individually and see a lot of suffering. And especially as with the Alaska Brain Bus Project, I travel throughout the state and have been doing that for 4 or 5 years into rural areas. And you just see a lot of people suffering that don't need to be suffering because of brain injury. So let's take a look at that, right? So what is a brain injury, right? So I did say a concussion is a brain injury, and that's shocking sometimes for people to realize that. Right, but basically a brain injury at the basic level of definition is an injury that affects how the brain works, right? And so we talk about traumatic brain injuries, which is a subset of brain injuries as a whole, and that's caused by a blow, bump, jolt to the head, a penetrating injury. And those are what we primarily see in the workplace, right? But there are other types of injury which you may also see in the workplace, right? Strangulation, near drowning, drug overdoses, strokes, exposure to toxic chemicals. I recall a patient who was clean in a tank. A respirator came off and he was exposed to lead. Those are the type of industrial accidents that happen. So there are many, many ways to injure your brain, unfortunately. And they can be consequential because research shows that once you've had one brain injury, you're twice or maybe 3 times more likely to experience a second. And then the second one makes you 8 times more likely to sustain a third, right? So it's almost this logarithmic sort of acceleration of TBIs. And that's, as a provider, that's kind of scary, right? So, and the consequences can be quite severe. And we do know that multiple traumatic brain injuries, let's say in sports, one right after the other can actually lead to death, right? And so they are not something to be taken lightly. And this is just a quick look at the things that happen when your brain is injured, because unlike getting a broken leg, you can still think, you can still, watch the TV, you can still talk on the phone, you can do all of those things. You might just hobble around. But when your brain is injured, you may not be able to walk, you may not be able to talk, you may not be able to think, you may not be able to look at a screen, maybe sounds are too loud. Everything changes, right? So a bunch of physical changes, which ironically make recovery more difficult. Things like you can't sleep, you got a lot of pain, you have trouble moving, even digestion changes rapidly after a brain injury. And then behaviorally, this is where we most often will see the problems. And certainly as an employer or a coworker, the behavioral problems are usually what causes the problems, right? This is what puts people in jail and gets them fired, right? So a whole bunch of those, right? Because our brain makes us who we are, right? It's how we express ourselves, right? And then the cognitive things, this becomes a problem as well, right? When we start to make mistakes. And of course, all these tie together into kind of this vicious sort of tornado of effects. So let's take a look at an example, right? So we'll call this guy Wayne. He was a heavy equipment operator. He was caught in a landslide at work. He was ejected from his truck, thrown down a 30-foot slope into a lake, and this was in the winter. He had significant physical injuries. It's amazing. He managed to crawl out of the lake and back up the slope to the road because he figured if he didn't, nobody would ever find him, and somebody actually did find him, right? So he was medevac to Providence. He was stabilized, sent to inpatient rehab because it's a workman's comp injury, right? And so many more resources are available if you have workers' comp, in theory. So he was at Providence. A staff member, a nurse said, you know what? I think you might have a brain injury. It was not on his list of diagnoses because they were worried about all the other physical things that had happened to him. And so Workman's Comp arranged for him to go to Center for Neuroskills in Bakersfield, California, one of the premier sort of rehab centers. He went in a wheelchair, covered in bandages, and 6 months later, he walked out on his own, right? Miraculous, right? Phenomenal. He could talk and he could walk, right? 2 years later, I met him on the brain bus when he showed up, because we just park and people show up. And he limped over to the brain bus and sat down and told me, if you tell me it's a miracle I'm alive, he said, I am going to kick you with my good leg. He said, I am so tired of hearing that. He said, I do not feel like a miracle. He says, I'm living in my mom's basement. I'm divorced. I can't get a job. I'm depressed. I'm drinking too much. He says, I'm a disaster. He says, I sometimes think I should not have survived. He said, I am far from a miracle. So, and I learned a long time ago, you don't tell people things like, wow, it's a miracle you're alive, because they may not feel that way. And Wayne is a good example of that. So what went right here, right? So some quick thinking and action saved his life. That's kind of like on the job type of stuff. The medical staff was very clever. They didn't diagnose the TBI right away, but it was caught a little bit later, and he got great rehab, right? But the focus was more on the physical aspects rather than the cognitive, because clearly he can walk and he can talk, but he can't work, and he's depressed, right? And he's drinking, right? So, and the problem is he was discharged from rehab with no supports, right? He went back to rural Alaska with nothing. He went from 6 months of excellent rehab to absolutely nothing. And nothing is going to get fixed in 6 months for an injury this consequential, right? There was no continued rehabilitation for cognitive skills. There was no return to work plan. Nothing. There was no bridge for him to get back to life. So we have a highly skilled worker who's now unable to work, depressed, and even suicidal, right? So that's unfortunately a fairly common trajectory for people that we work with in Alaska, because these are consequential injuries. Here are some statistics that show you how consequential these are, right? Not everybody with a concussion or a brain injury is going to have problems, but somewhere 25 to 30% of people do. And these are the kind of problems they have, right? 400% increase in suicide. That is phenomenal. And personally, after my traumatic brain injury in 1998, I was suicidal. I have lived that. I have felt those feelings, and it's strange, right? I fortunately did not go to prison. I did not get addicted to substances. A lot of people do. I did not become homeless, and I was not diagnosed with a mental illness, right? I was very fortunate. A lot of people are not. So why is it we don't know more about traumatic brain injuries? Well, we hear a lot about cancer, and here's some statistics. 2020, 1.8 million cases of cancer were diagnosed. 606,000 people died, right? That's big. That's actually quite huge. However, 1.7 million TBIs were diagnosed, and 69,000 people died. So almost the same number of cases, right, of diagnoses, but fewer people died. So the end result is that we have 1.63 million survivors out there each year. That's a huge number of people who may or may not have gotten any rehabilitation. And I would argue that most people, especially in Alaska, do not get any care, right? they may not even ever see a doctor or any provider, right? So just surviving doesn't mean you're ready to go back to normal life or to work, right? So we've got a huge number of people that are basically staggering around out there. They may look just normal, right? A lot of people with brain injury look normal. I look fairly normal, right? And I've learned to act fairly normal. But do I have some deficits? Yes, right? But I did a lot of treatment. I did a lot of therapy, right? So why do we not pay attention to this problem like we do to cancer? Well, one is ignorance, right? A lot of people just don't know about it. There's a huge stigma. When you have something with your brain, people are just like, oh, no way, I'm not dealing with this, right? And most of us look just fine. And it's complicated to diagnose a brain injury because everyone is different, right? They may share some similar sort of threads or themes, but they are very different. And that's difficult for medicine. Medicine doesn't do well these days with difficult and diverse things, right? Their goal is to figure out what's going on with you, get you the diagnosis, and find the pill that's going to fix that problem. There's no pill for brain injury. If there was, somebody would be making billions of dollars, right? And trust me, I've talked to researchers and people who work for pharmaceutical companies. They have worked very hard at this, right? Because the market is huge, right? So as a result, brain injuries proceed to be difficult to treat, expensive to treat, and so we just ignore it, right? And that's unfortunate because we're losing a lot of people to this, right, from the workforce, right? So let's take a look at Alaska specifically. So we have the highest mortality rate from traumatic brain injury in the nation. It's double the national average. In the native population, it's 3 times the national average, and that's pretty consistent, along these years, right? So that's huge, right? Considering also the fact that we have such a remote state and we have very little, almost arguably no resources to treat these people. Not unsurprising, males are impacted much more commonly than females. And there's lots of reasons for that, including, bad behavior and just being a guy, right? And this is an interesting graph chart because it shows you not only the ages at which brain injuries are happening, but also how it happens, right? And this is Alaska specifically, and this is just from hospital data. So you can see the big peak is 15 to 19 years old with a couple shoulders there. So basically young people, right? And then there's another peak as we get older, right? And you can kind of see that falls are a big piece of this. Unintentional falls, which I always think is kind of funny, like there are intentional falls. I don't know. So unintentional falls are the gray boxes, right? So, or I'm sorry, the green boxes. And so those go way up, right, in our older age, whereas the younger adults are being impacted by all sorts of different things, right? So bimodal distribution. And if you look at like when are people entering the workforce, when are they going to school, when are they getting trained, it is that 15 to 24 or to 20 to 34. That's where a lot of stuff is happening. And if you're having brain injuries, that means your life trajectory is very different. So here you can kind of look a little bit easier to see, what this looks like. Falls are the big ones, motor vehicle crashes, and that includes snow machines, four-wheelers, that kind of thing. Assault, not inconsequential, right? And it's important to know, especially if you're looking at employers, that if a traumatic brain injury happens on the weekend when you're out four-wheeling, you come to work with that TBI, it impacts your performance at work. So we all need to be concerned about this, not just on the job site. We need to be worried about what are people doing in their life, how well educated are they to be safe at home, right? And that's no different than any other safety thing, right? But we don't pay much attention to brain injuries, right? We kind of like, hit your head, you'll be fine, right? So, but if that were to happen on the workplace, that's more likely to be reported, right? But not always, right? Sometimes people are just not aware of it, right? Or they're actually discouraged from reporting it, right? So we can't just rely on that, right? And I think the real reason why, and I've seen many patients that are in this conundrum, if they report their traumatic brain injury, whether it happened at work or at not, they're afraid they're going to lose their job or that their hours will be reduced, right? So they go back to work, very unsafe, really bad for their recovery, right? The people they work with, their supervisors, may not have any awareness or any education around traumatic brain injury, so they can't advise them, they can't help them seek care. There's a stigma. I worked with a patient who did not want to see a therapist in his community, did not want to go to a support group, did not want to see a provider, because if in that small town, if somebody knew he had a brain injury and something happened at work, they would blame him whether he was responsible or not. It's like, oh, the guy with the brain injury, right? So, which is a very real, that's a real situation, right? So, and if you do start talking about your brain injury, people don't understand, like, how you just got a little smack on the head. How can it be that consequential? You must be making it up. You're trying to game the system. You're trying to get money from workers' comp, right? You know, you're malingering, right? There's something else wrong with you. You look like you're drunk, right? And the problem is old symptoms or even older brain injuries can be exacerbated by a new injury, right? And if you're in a workplace where you're struggling with a brain injury, the environment in that workplace may make you more symptomatic and make you worse, right? And definitely one of the worst ways to recover from a brain injury is to go right back to what you were doing before in many cases, right? So we don't want you to just sit in a bedroom in the dark, but we don't want you to go back to a stressful job or a job that's actually dangerous, right? If you have balance problems or cognitive problems, you do not want to be back at work. So huge human costs that we've looked at, but what about the money cost, right? So there are people out here who money matters more than other things. So this slide is for you, right? So this is a lot, $19 billion annually for the people who survive traumatic brain injury. And this is kind of how it breaks down. People can't work, they come to work late, they just don't show up, and household productivity drops, right? So even from the money perspective, this is a big deal. So, and this is probably not surprising to any of you, the people who are most impacted at work, construction is always top of the list, and there's a lot of reasons for that, all the way down to loggers, right? Like I said, many ways to hit your brain and cause problems. So data shows nationwide that a quarter of all traumatic brain injuries happen at work, primarily from falls, slips, trips, being hit by something, motor vehicle accident, and then some of these other ones. And the assaults is always kind of interesting, but I've been working with a number of law enforcement folks. It is shocking what those people put up with, right? I think we really need to give them a lot of respect. Those people are beaten up almost every day on the job, and seriously sometimes, right? So assaults are a thing, right? Even in the workplace. So, like we saw with Wayne, TBIs are often ignored if there's other, what they call polytrauma, so there's other things going on in the situation. They're invisible, and sometimes people themselves don't even know they had a brain injury. I went for 7 years not understanding why I was so different, because my brain injury was not diagnosed when it happened, right? Because of the polytrauma situation, right? And problems don't always show up right away. You might be fine for a couple days, or maybe even a week, and then your world starts to fall apart, right? And TBIs now are officially a chronic lifelong issue, right? That doesn't mean they need to be a problem your entire life, but the thing is they will always be lurking there, right? And so we need to look at this as a lifelong problem. We need to provide supports for people throughout their life. We can't just fix them once, you're good to go, right? And new research is showing what they call subconcussive blows. So these are little blows to your head that don't register. You don't end up with a headache or blurred vision or anything like that. These add up over time, and people can have hundreds of these, right? So, and the last thing before Audra jumps in here is a lot of traumatic brain injury also involve injury to the neck, which is kind of ignored. And neck injuries can cause a lot of the same symptoms that we attribute to the brain. So that neck needs to be assessed and treated as well. So, all right. Now, one more slide for Audra. So in Alaska, we really have very little capacity to treat brain injury. We do not have a level 1 trauma center in the state at all. You have to fly to Harborview in Seattle. So nobody makes it within that golden hour to get treatment. Nobody, right? Most people go home with no support, no rehab plan, because most places in Alaska have nobody who knows how to treat brain injury. Workman's comp doesn't understand the cognitive rehabilitation and oftentimes refuses to pay for it, right? So people don't have access, right? And a lot of people I work with go home to Alaska, they become isolated, they give up seeking help, and they just disappear literally into the woods, right? And so we're losing a lot of the workforce in Alaska because of traumatic brain injury, and that is or we need to be doing something about this because brains can be healed. We can improve diagnosis and treatment. And we also, as Audra is good at demonstrating, brain injury rehab doesn't need to be expensive, and it can actually be provided remotely. And so we can get people back to work and life, and that is our goal, right? So we'll start with this very scary slide for Audra to talk about what does it look like if you're going to treat somebody with brain injury.
Thank you. So, very quickly, I think the biggest thing that I can offer is to say that early treatment is definitely important, as well as recognizing that a lot of people will hear, oh, well, you're going to get as good as you're going to get in 6 months, and then that's it. That's simply not true. I unfortunately often get people a year after their injury or 18 months, and there's still quite a bit of work that can be done. Yeah, it's better early on, but sometimes you, like Dr. Grove said, when you have a polytrauma and you have, a broken ankle and a shoulder and some neck, and you have so much pain, you're maybe not ready for cognitive rehab or some of those higher level things. And so I think it's important to understand that just because someone continues to struggle 8, 10, 12 months after their injury doesn't mean that there isn't recovery to be had with the right support. Another thing that I think is very important, especially within the workplace, is that people who've had a brain injury, like Dr. Grove said, they're really struggling with probably an intangible loss. Often a person does not understand some of the skills they may have lost or that may be difficult until they show up. And a lot of times in a work environment, that's when you have to combine your ability to sequence things, follow instructions, know where you're at in space, and make judgment calls and make decisions about your environment that may be always changing. And that can be very hard to know if you can do that until it's required. And often you may not be able to do it at the pace or in the same way that you did before. So one of my roles when I'm working with someone who's struggling at work or getting back to work is helping to understand what their job requires, what those cognitive demands are, and then even having conversations with the patient's permission with an employer to say, okay, so what are some reasonable ways that we can support this person that don't necessarily diminish and are not undoable for the workforce, but can we maybe adjust their work environment? Can we adjust their hours? Can we alternate tasks so that they have a physical task and then a cognitive task? Can we arrange their concentration to the time of day where they're sharpest? Can we make accommodations for lack of sleep or increased pain? Those sorts of things is the role that I come in. And the biggest thing that I will stand on my soapbox just for a few minutes here and say is that vision is key to learning, to interpreting our environment, to processing our environment. And as someone who specifically treats people with visual disorders, not sight, but vision, that is almost never screened. And that is one of the things when people come to me many years later, it's like, they're saying, I can't look at screens. I can't read my phone. I can't switch between a screen and a phone or, move my head. So vision and vestibular issues are often something that shows up, and it's very subtle because our vision system, yes, we can volitionally control where we look, but there's a lot of things that happen with your visual processing that are not necessarily under your control that your brain is taking care of for you, thank goodness. And we don't realize when that might be malfunctioning. We recognize that we have more headaches, that we have more fatigue, etc. And so I think one of the biggest things that I would just offer to everyone on the call is if you know someone who's had a brain injury and they're struggling and maybe they're okay, but they have more headaches or they have more confusion or reduced stamina, always have them check to see if their vision has changed, their prescription might have changed, and then get them to someone who can who can help them see if there are maybe some processing deficits that are using up some of that. I call it like cognitive reserve that make everyday tasks a lot harder. I do want to be respectful of time and make sure that we get to Dr. Arzubi. I really appreciate the combination of talking about brain injury and mental health, because so often the reason brain injury, and I tell people brain injury is very unique because so often our identity is wrapped up in of who we are is attached to what we can do. And then when we lose some of those things, we lose some of those, what can we do? It can be a blessing because we can get reacquainted with who we are, who are we inherently, how are we inherently valuable as people when maybe we don't have a skill that used to kind of give us some of our identity, but that can be very hard. And so working through that process with someone is kind of part of the recovery process too, that you may have lost a tangible skill, and sometimes it can be surprising and heartbreaking. You suddenly can't do math or calculate a tip, or those are things that you don't always realize, or your handwriting is bad, but helping someone process that doesn't mean that you have lost inherent value as a human. That means you have some things that you struggle with in the same way that you don't, you would not look down on a person with a broken arm, or who's using crutches, or who's using a wheelchair, or needs some support. That doesn't make you less of a person. It makes you someone who needs some support and is struggling with a particular injury. And so I think that part of brain injury recovery is really important. So I really look forward to what Dr. Arzubi has to say too, and how to build resilience, because that's a big part of brain injury recovery.
Sorry about that. I got a little bit behind on the slides there, Audra. So
It's okay.
just to finish up, there's resources. I also put those some of those in the chat, so you can just click on those links. And thank you, Jacqueline, for correcting that one link. And then our contact information. Audra and I are both always happy to get emails from people. Feel free to reach out. We're happy to help talk about this more, answer questions, and actually, I don't know. Mari, if we just have a couple minutes. I don't know if you want to open it for questions now, or if we should just stop here.
I think we have a couple minutes for questions. If anyone would like to ask a question, feel free to jump in. You can put it in the chat or just raise your hand and we'll call on you. Go ahead, Amy. Taylor, can you help me unspotlight? Oh, okay, here we go. Let me remove spotlight so we can all see each other.
Thank you for such a great information. I am Amy with Alaska Literacy Program, an adult education program here in Anchorage. And I'm just wondering, I know it's not exactly a TBI, but I'm sure it's a brain injury, but like how long COVID has impacted some of the things that you're talking about and what you're seeing.
Yeah, well, a long COVID can, in many cases, be considered a brain injury. The research has shown that it does cause brain damage, and people don't always like to hear that. But there's many of the symptoms, I think Audra probably would agree, when we see people with long COVID, we look at them and say, wow, this is a brain injury, right? The symptoms are so similar. And research shows there's microclots, the blood-brain barrier becomes more porous, there's an immune response. These are the things that happen with brain injury. So yes, it is a brain injury, and it responds really well to being treated the same as we would any other brain injury. So excellent question, Amy.
And I would say too, again, with like the cognitive reserve piece. So one of the things that Dr. Grove had talked about is it's cumulative. And so people may have had several subconcussive bonks, and then all of a sudden it's like, well, this is the one that now I can't work. And that's not actually the case. And I talk to people about, think of having a savings account. And after, you might be able to draw out of that savings account and still have a cushion. 3 or 4 times. You might have your car breakdown, and then you might have a surgery, and then you might have, you have pet emergency. But eventually, that last emergency where maybe you have to replace your furnace, that causes your account to be overdrawn, and it's going to be really hard to put that back in. And so with vision, this is, again, I'm a vision person, and it's really important. And so there's a lot of people, if we tested everybody on this call, it's very likely that you may not have perfect binocular vision. You may have intermittent suppression, that your brain is really smart and it compensates for you. There might be some speech things or some memory things, that you may have a comorbid, you may have an ADHD, or you may have, a depression, or you may have some other things, and your brain and your body is very smart and it's compensating, and it uses some of that reserve all the time, and you're functioning. Well, now we have that next injury, subconcussive or concussion, and suddenly we maybe can't make it to work on time. We are a little bit irritable with all of our coworkers. We snap at our boss, or a little disrespectful. We can't regulate, right? Because we have lost that reserve, that cognitive reserve that helps us manage those, life's waves of up and down. We don't have that anymore. And so each little thing tends to knock us a little bit further, and then that can be cumulative. And so when you have that issue, a lot of times people are like, well, did I have this vision issue before? Maybe. And your brain was figuring it out, but now you can't. And so your brain's like, I have to survive. I have to regulate my body temperature. I have to, regulate my heart rate, all of those things. I have to manage the environment around me if it has bright lights and lots of people and sounds and phones going off the hook or machinery. And so your brain is busy processing those things, and it lets something go. When we eat turkey dinner, our blood all goes to our gut, right? And the extremities get cold. The brain does the same thing. It's like, I only have this much money, and we're going to put it to groceries and rent, or maybe it's, heat in the winter, whatever that is. And so some of the other little processes fall apart, which can be very challenging and very functionally impactful, even with a minor TBI, a little bonk to the head. So, and as someone who works in literacy, language processing, reading, oh my goodness, reading is on screens or on paper, huge impact. So.
Well, thank you both for this very engaging presentation. I see some more questions in the chat, which maybe you can answer in the chat, or if we have some time afterwards. Thank you for your emails, so people can also follow up after this session. We're gonna highlight Dr. Arzubi now, and as Dr. Grove and Yewchin spoke on the importance of early treatment, we're now going to talk a little bit about the challenges that we face in access to mental health care, particularly in rural workforce settings where we have such provider shortages. And I know Dr. Arzubi is going to talk a little bit about an innovative solution to meeting some of the care needs of Alaskans. So with that, I'd like to introduce Dr. Eric Arzubi. He is the CEO and co-founder of Frontier Psychiatry, a telepsychiatry platform serving rural and frontier communities across Montana, Idaho, and Alaska. Frontier has been caring for Alaskans for over a year and accepts Medicare, Medicaid, TRICARE, TriWest, and as well as commercial insurance. And with more than 30 providers delivering roughly 50,000 patient visits a year, Frontier has demonstrated a 38% lower psychiatric hospitalization rate among Montana Medicaid patients. And this was published in the Journal of American Medical Association. Dr. Arzubi is board certified in both child and adult psychiatry, and serves as an assistant clinical professor at the Yale Child Studies Center, where he completed his medical training. Based in Billings, Montana since 2013, He built the state's first psychiatry residency program, Empath Unit, and Project Echo Hub at the Billings Clinic. And before medicine, he traded bonds at Morgan Stanley and reported as a Latin American correspondent for Bloomberg. And I have to say, both Dr. Grove and Dr. Arzubi really highlight how career pathways are not linear, right? Dr. Arzubi is a TEDx speaker. He's appeared on Oprah Winfrey's The Me You Can't See on Apple TV, and is the top-ranked psychiatrist creator on LinkedIn, according to Favicon. He believes rural communities deserve the same quality psychiatric care as those living in major medical centers. Thank you, Dr. Arzubi, for joining our call today.
Well, thanks for having me. First of all, Dr. Yewchin and Dr. Grove speak in the same language, and was great to hear. I mean, really what I heard is, especially, when you're talking about kind of the recovery process, basically what I'm hearing is you're recommending you do everything you can to get out of the brain's own natural way of repairing itself, right? By sleep, eating, right, giving it rest. So anyway, I just love the approach and the education. So thanks for that. I still do disability evaluations about once a month for veterans with TBI, and so everything you talked about, I see, and it's brutal, but it's great to have your services and give people some hope. So thanks for what you do. Let me share. I'll share my screen. Okay. So, all right. It's weird for me to give presentations without seeing people's faces. I'm not very good at this, but I'm going to give it my best. So here we go. So as we know, right, it's, oh, shoot, why does this stay, oh boy, did I fire up the wrong, sorry, I may have fired up the wrong presentation. This might be the one from, oh shoot, the Alaskan.
It says BEC. Okay, yeah, there's.
Yep, sorry guys.
No worries.
Let me see. Yeah, this is. No, I fired up the wrong one. Let me, as I do that, I can get started, and again, I apologize. So big picture, I think the biggest takeaway I'm going to ask you to consider after listening to this presentation is there's something that we don't necessarily appreciate, and we talk about there being kind of a this mental health crisis and the shortage of resources. Sure, there is that challenge, but what I invite us to think about is we do a pretty terrible job making use of the resources that we do have available. And so what I want to think about is how can we be more creative and innovative, making good use of the resources that we do have and make them go longer, right? In general, most behavioral health interventions, they're designed near academic centers. They're designed to be for patients to be able to show up in person a lot of the time, be seen 8 to 12 weeks, to come every time for a session, right? So there are all these kind of stipulations and all these requirements from the patient side to make this work. But what are we doing from the provider side to actually make this more accessible? So let me just give you just a little bit of background about Frontier, who we are, just to give you a little bit of context. So as you heard, we were started in 2020. We deliver care across Alaska, Idaho, Montana, and started Frontier, like I said, in 2020. But since 2013, I really fell in love with the challenge of making high quality care accessible to people no matter where they live. And given the technology and hopefully our openness to think more creatively, this is possible. So I guess I want this to be a hopeful presentation, that there, and in the same way the earlier presentation was hopeful, same thing here. We can actually do things better and do things only if we do things differently. What we can't do is keep complaining that we have a mental health crisis and then not make any changes, because we're going to be having the same presentation 10 years from now going, wow, we still have a crisis. Well, there are things we can do. And again, a little bit about us, we try to do our best to keep track of our data. So making sure, are patients getting better? Are they satisfied with the care that they're getting from us? And we try to do everything as data-driven as possible, in addition to the data that we described before about hospitalization rates, right? It's nice that our patients like us. I love that. But what I care more about is, are my patients actually getting better? Like, this is not a popularity contest. I want to know that the service we're delivering is actually helping people. And the reason I do care about whether or not they like us is they're more likely to come back and stay engaged in care. That's really the purpose about that. So just like Dr. Grove and Dr. Yewchin had a person talk about, I got somebody too. This is James, right? So you got a welder on North Slope. He's skilled, experienced. He's showing up every day, but something on the surface isn't working, right? He's sleep deprived, self-medicating, with alcohol, maybe other things. His hands shaking every morning on the job. He was written up twice by his foreman, and there's no help nearby to kind of get an assessment or even any kind of intervention, right? So again, this isn't a problem because it's a James problem. This is a problem because me and my colleagues haven't done a good enough job in getting the right care to James when he needs it. This is not a James problem. This is a me problem, right? I got to own this problem if I'm going to deliver care. So, right. So Alaska's workforce, again, I think you talked, the presentation before touch on some of this stuff, right? But the average worker in Alaska has like 2.7, almost 3 co-occurring conditions. So there's depression, anxiety, PTSD, and substance use disorders. These really make up, right? You guys have heard of the 20-80 rule. So probably these 20% of conditions make up 80% of what's really happening, right? So these really are what you see the most of. There are other things, but you see a lot of this. And again, they show up together. And again, like Dr. Grove said, you can come at this from 2 different angles. You can pull at heartstrings and say, this is a real problem. We don't want people suffering. On the other hand, you also got to talk a different language, which is dollars and cents, if you're going to convince people to actually invest resources into this, right? So there is an economic burden on this. So not only do we have kind of a moral and ethical obligation to address this, but really financially, it's the right thing to do, because people who are depressed, anxious, have substance use disorders, PTSD, when they show up to work, they're not functioning at 100%. And there's a cost to that. So when they show up, there's a cost to that. And when they miss work, there's a cost to that. So again, that's sort of the financial case for organizations to really tackle this head on. So, and we know this, mental health is a physical safety issue. We know that it can affect inflammatory pathways, elevated blood pressure, impaired judgment. I mean, one of the things I struggle with is anxiety. I've got my good months, my bad months, but during my bad months, it's hard for me to focus. Because I'm sitting here stewing on things, right? And I imagine a lot of us has felt that, right? So it affects us in many ways. And treatment does save lives. And what's cool is mental health treatment. So if someone has obviously, if we're tackling mental illness alone, mental health treatment saves lives. But what's also really cool is there's so much data showing that just by giving somebody with chronic physical illness mental health interventions, you actually improve overall whole person health. So here I give you some data on some studies that have been done. So for example, look at the look at the 26% number. Okay, that study was from they did purely a mental health, a behavioral health intervention on a bunch of veterans who had cancer, and they lowered all-cause mortality by 26% just through mental health treatment. It wasn't chemo, wasn't radiation, it was mental health treatment. The 67% number, patients with heart failure and coronary artery disease who received mental health treatment, just the mental health treatment alone was the difference, lowered mortality risk by 67%. So again, we are not leveraging mental health interventions to its fullest extent by any means. And again, here's the ROI, and you can go through it in detail, but the case is there to be made on how much money you can save by investing in behavioral health interventions. So again, Alaska's access crisis, I'm in Montana and Idaho as well. And actually today I happen to be in Utah at a conference around mental health. The access crisis is everywhere. Obviously, Alaska is special in terms of the absolute size and the size of the healthcare deserts. But again, it's a common challenge. But there are ways around this. There are ways around this to actually tackle this head on. The research, again, like I said, the research that was done around behavioral health interventions assumes that people show up for weeks at a time, and that's not always true, right? So imagine if we actually designed interventions for the one session people actually show up for. And what I mean by that is the following. The most common number, and this I hope I can impress this upon you to remember, the most common number of behavioral health visits nationally, even internationally, these are actually studies done internationally, so my mistake. The most common number of behavioral health visits is one. One is the most common, right? And so you think about like this histogram where the frequency of visits is 1, that's the highest number, then 2, then 3, then 4, and it trails off. And a lot of times these first visits is it's an hour of collecting history information about background, which is appropriate based on what we've always been trained to do. But imagine that we deliver an intervention right up front that improves outcomes and improves engagement, right? So these are single session interventions. So a single session intervention is a structured program that was intentionally designed for just one visit. And what this slide is designed to kind of convince you is this has been studied a lot. The most prominent researcher is a woman named Dr. Jessica Schleider. Dr. Jessica Schleider, let me just share this real quick with you. She runs this lab, the Lab for Scalable Mental Health at Northwestern University. She's been studying single session interventions for the last 10 years. Single session interventions are not new. They've been around since the 90s. What is new is Dr. Schleider's approach to studying these in randomized controlled trials. She's studying them in a couple of different ways. Number one, she's studying them as interventions that are delivered by humans, so human to human, one single session intervention. And she studied them as digital self-guided interventions. And mostly she studied them in youth, but she's doing more studies now in adults. So by just having one intervention, you can impact anxiety, substance use disorders, depression, and suicide risk. Now, I think, I'm going to guess a lot of us have heard of a safety plan, right? A safety planning that happens sometimes in emergency rooms or after behavioral health crisis. Well, guess what? A safety plan is exactly a single session intervention. So most of us have heard of single session interventions already without knowing they're actually single session interventions. And a safety plan is a proven single session intervention that's designed to lower suicide risk. So this is nothing new. So, and the other key piece here in terms of the research is there were none of the reviews that were looked at showed any adverse effects from single session intervention. So let me continue. So what is it? So you're gonna see me say I mentioned SSC and SSI, and I apologize, but I'm trying to be kind of very specific. So SSI is kind of the generic umbrella term of single session intervention, and SSC is the person-to-person model, but the same framework applies. So what is it? Well, again, it's grounded in solution-focused brief therapy, right? So you're supposed to be looking at what's happening today. It's action-oriented and framed as a consultation, so not therapy, which is important because for two reasons. Number one, if you call it therapy, some people might get spooked by it. Number two, non-licensed professionals can be trained to deliver single session consultations, which means you can scale this, right? And the whole idea I want you to walk away with from today is I'm always thinking about, and I hope we're always together thinking about what are ways to scale access to high quality behavioral health interventions that are proven, right? So you don't want to just scale any kind of app that shows up. You want to scale stuff that's been proven and tested. And so the more we can do to actually scale access to care, that's where we're going to start solving some problems. So again, what's the SSC model have? It's about 30 to 60 minutes. So, right, you can fit it in, and that's the one intervention. And remember, it's designed for that one time. The approach, like I said, it's solution-focused brief therapy. It's framed as a consultation, which removes stigma and lowers the barrier to entry. And for people to get trained, it's a 2.5-hour training. So it doesn't take a lot of training. So what's nice is by scaling training, you can scale access to the care. This goes over kind of the SSC protocol and what's involved. These are basically the ingredients that make it a single session consultation. So I'll go kind of quickly through these eight elements, and we can always come back to it if you have questions. But right, so you establish in that moment, okay, what's the purpose today? We're going to align on what we're going to talk about. What's the top problem, right? Because if you talk about 20 problems, you're really not talking about any problem. So you're going to identify the top problem. You identify then the top hope. Then you pose what's called the miracle question. And the miracle question essentially asks, if miraculously today, your top problem were to go away, what would your life look like? And then number 5, you look at a progress scale to see kind of where you are today on kind of getting to that point, and what would it take to move you up one step from, let's say, a 4 out of 10 to a 5 out of 10. You explore exceptions. You identify, okay, you're saying nothing works, but are there moments where things do feel better? And so helping uncover things that are potentially helpful, making a 3-step action plan. So again, it's action oriented, and then following up at the end with kind of a note of confidence from the person giving the intervention. And so these ingredients alone have contributed to these outcomes. You decrease hopelessness, you improve agency, right? The feeling that, oh, you can actually change the way you're feeling, and decrease distress. 10% of people in these studies who got it didn't need further treatment, right? So basically the single session consultation, out of 100 people, 90% afterwards needed a follow-up care, but 10% were okay, right? So again, you're making better use of resources. So instead of giving, 8-week cognitive behavioral therapy to all 100 people, you give all 100 people one session. And then after that, you see, okay, who's in a place now where they don't need more, and then you see kind of who's left. And then you decide, based on that first intervention, what that group then needs. But you're making better use of these resources. The other powerful thing, the other thing I want to kind of mention too, is this is not designed to replace treatment as usual. What this does is it eliminates wait times. It uses, again, it's a more efficient use of resources because you're not giving everybody the same darn tool, like, an 8-week cognitive behavioral therapy. So it's allowing you to kind of stratify and triage. The other thing is people who have done single session consultations or interventions in general are actually more likely to follow through with treatment as usual in the community. So what it actually does is it makes it stickier for people to actually follow up in care as usual when we're able to kind of create a bridge and then make it more likely that they'll engage. What's nice about digital single session interventions is, right, they're accessible 24/7, anywhere, anytime, and again, have been proven to be helpful. And I'll show you something real quick here. So we at Frontier Psychiatry, so as you might know, the University of Washington runs the psychiatric access line for Alaska, and that's for child psychiatry and I believe perinatal psychiatry. We at Frontier, we run it for Montana. And we did something, I think, pretty exciting with the state of Montana. So the state of Montana allowed us to take some of that funding. And what we did is we worked with Northwestern University's Lab for Scalable Mental Health, and we rolled out digital single session interventions for youth in Montana for free, for kids age 11 to 17. So right now, this is live, this website's live. This is called, it's montana.projectyesguy.org. So if you click here, so this is kind of the toolkit. It educates people about what Project Yes is and what single session interventions are. But this is where kind of youth go. And Project Yes, there's a 5 to 10 minute self-guided digital courses that are based on what I just described to you, the single session intervention ingredients that allow you to improve your mood, rethink body image, reframe negative thoughts, know your power to change, take steps towards your goals. So these are actually the interventions, the digital interventions have been proven to actually help reduce distress and improve functioning in youth age 11 to 17. And so this is now available for free for Montana kids. Thanks to the work we did with the state of Montana and Northwestern. Let me continue here. So in general, when you think about different levels of support, think about it this way. Patients who are at low risk, and we're talking about low, moderate, and high risk, right? We're thinking about low risk for really bad things happening, right? So, or decompensation, so self-harm, suicide, and other kind of things that require behavioral health emergency. So people who are at low risk, you can deliver low human touch, high-tech interventions because they're low risk and you can scale, and there are more of those, right? If you think about the percentage of the population who are at low risk versus high risk, there are many more low risk people than high risk people, but there's still a lot in every tier. So how do we actually spread access to care and make sure it's the appropriate level of care, right? Because we can't give everybody a psychiatrist, and we don't want to give everybody a digital single session intervention. So we got to tier these things. So at low risk, you can give somebody low human touch, high tech interventions that are proven and tested. And as they become more moderate risk and then high risk, you want to dial down the amount of technology and you want to dial up the human touch. But again, only by tiering things are we going to do a better job actually making this care accessible, because that way we're not throwing the same thing at everybody. Let me continue here. This I think is a really cool, and this is very, very applicable to you all, especially when you think about employers and companies and employers. Amazon partnered with Northwestern University to do a pilot. They said they took their EAP people, a group of their EAP people, and got them trained in single session consultations. So what did they do? They kept their EAP, the people that got trained, access to them 24/7. So obviously they had shifts and so forth. They found that 27% of them experienced meaningful depression relief after a single session, right? So again, remember what's happening. They have 100 Amazon employees who are seeking out EAP. The first thing they get is a single session consultation. After that, you go from 100 people to now 27 of them felt meaningful depression relief, and the remaining 73% will probably need care, ongoing care. But what you did was you provided immediate relief to over a quarter of them. You are able to triage to figure out who needs more and who needs less care. And you're able to scale access to an intervention that is proven to work. So, and what's nice is, again, as it states down here, this model was not designed just for Fortune 500 companies. Anybody who has employees and can access an EAP, and if you get your EAP people trained in this, this is a great tool. So 5 steps for Alaska. This is kind of what are some ideas for you all. So get people who are doing EAP, the actual EAP therapists, get them trained in single session consultations now. Just get them trained, because again, you're not going to be bringing in every single person who's struggling into a 10-week, half year. Like, in behavioral health, we're famous for wanting to hold on to our patients forever. That is not going to work. It's just not going to work, and we need to think differently. So train who you can in single session consultations. Deploy digital single session interventions. I know people get freaked out about digital AI and all that kind of stuff. I get it. But if you look at the tools that are proven, you don't just pick some random app from the App Store, right? There are tools that have been really, really hardwired and tested to actually work. And that's where you start thinking about, okay, who are my low risk people? I can give them low touch, high tech solutions while I deploy my people for the moderate and high risk patients, people who need our services. You can train supervisors and mental health navigators, help them understand the access to these resources. Reframing mental health as a safety issue, as many of you are already doing, and I saw that happen at the governor's conference on health and safety. And then, pilot programs within your companies and start doing it now. Don't wait. Just start, because whatever we're doing right now in most cases isn't working. So you've got to try something different and start today. I think, oh yeah, back to James. So again, the idea with somebody like James, who was kind of, really far away from any kind of access to care, if he was given access either to someone over video who gave him a 30-minute single session consultation, or maybe he was able to get by with a single session intervention that was digital, he was actually maybe able to feel a little bit better and start moving the needle, right? So he'll have faith that there's something out there that's helpful and access to it pretty quickly, right? Because I think too often we in behavioral health care, because we make people wait and then we give them interventions that aren't necessarily appropriate, people kind of get sick of it. They're like, this isn't for me. This doesn't work. And so we on the behavioral health side need to do better. And so again, there are tools that will actually make a difference and make this access to care more scalable. And so that was my last slide. And really, there are two things I invite you to think about. You can scale. There are two ways to scale. One is you scale by training your people. And we have, so I'm working right now with a group called San Luca Health. They're a technology partner. And they're building out two tools. One is a single session intervention training tool, so that, so for example, if you have an EAP group or you have therapists, wherever your resources for your employees, you sign them up for the training tool. They go through the training, and this tool is really cool because not only does it teach them go through the actual protocol, but it also gives like AI-based test patients to make sure that people are delivering the intervention to fidelity, right? So it's not just like, oh, multiple choice answers. No, you're actually now, the people who are getting trained are being forced to answer questions in real time. Are you actually able to answer in a way that has fidelity to the model? So that's one tool where you can quickly scale training to a lot of people. And then the other tool is the actual intervention, right? So you can actually say, hey, look, I don't know if I have enough EAP people, but I certainly have a lot of employees. Let me give them a digital single session intervention first, and you can make that accessible right away. So with that, I will stop and be happy to take some questions. Sorry, one more thing, and I'll shut up because I'll keep going. There are these tools, but remember what I said before. Low risk means you can do high tech, low touch. Moderate to higher risk, you need to do lower tech, higher touch. And so we frontier our care, right? We're psychiatry and therapy first. So and I don't want to hold on to our patients forever. I want to be able to help them and move on. We work really hard to be able to help the folks with moderate to severe illness, but on the side where they're kind of low to moderate risk, we also want to be able to help provide solutions, because not everybody needs us. Not everybody needs medications. Not everybody needs to see a psychiatrist. So for those that don't, we want to be helpful in making sure that people get access to stuff that actually works. Okay, now I'll shut up.
Thank you so much, Dr. Arzubi. Are there questions? Go ahead and put them in the chat or raise your hand and unmute. Dr. Grove, go for it.
Wow, thank you, Eric. Why didn't I know about this before? Right, this is amazing. And so, how do people go about getting trained in this? And how do we spread the word on this as a tool?
Sure. So again, hopefully it came through. I'm kind of passionate about this. So I'm always happy to be helpful and be a voice, but also happy to share information that will allow you and others, right? So to continue the education process. So I'll do whatever you need. We have this toolkit. I can work with the Lab for Scalable Mental Health and others to kind of create a toolkit if you think that if there's a defined audience, Adam, that you want this for, I'm happy to work with you on making that happen. But again, quite simply, the tool is the tool developed by San Luca. And here's I'll give you the kind of the history there. I reached out to Dr. Schleider like 4 years ago. I read about a paper she wrote. I think it was like 4 years ago. It was like in Nature Medicine or something. Like, I can't believe I had the same reaction you did, Adam. I can't believe I didn't know this was a thing. And so I called her, I reached out to her, I go, Jessica, I need to know more about this. So tell me, So I got really well versed in this. I met with her lab. I started doing some stuff, across the state of Montana. And then I'm like, we need to make this scalable. And the only way to do that is using a digital tool. And so I came across actually a group called San Luca Health. They're an AI digital behavioral health developer. They actually, I got introduced to these people actually by Dr. Tom Insel, who was the former head of the National Institute of Mental Health. He's I don't know if he's still like an advisor to them or whatever, but you know, I kind of trusted the guys. So I'm like, all right, these guys might be legit. They're not just creating random apps. And I talked to them. I said, you guys need to develop an SSI tool. So they took the research from Dr. Schleider, used her actual manual to develop the single session intervention tool, the actual intervention tool, and the training tool. So so again, so if anybody's interested, and I can make the connection to San Luca. If somebody says, hey, I want 100 people trained on this tomorrow, I'll connect to San Luca and you can do that tomorrow. Like the training tool is ready to go. You just need to get, and again, what's cool about the training tool is you get the training, but then you also get tested on actual patient scenarios that you need to actively be answering, which is something really cool that AI can do. It can create different patient personas to test fidelity, right? Because that rarely happens when people get trained in behavioral health interventions. Like, you know, you sit in a lecture, you answer multiple choice questions, and good luck. But this tool, an AI tool, allows us to dig even further to make sure there's fidelity to the model. Next week, Christy and I are actually going to a school district in Montana, and we're going to be helping them deploy this training tool to all their school staff. Mm-hmm. So, right, think about how often teachers and people in school buildings are called upon to have conversations related to emotional behavioral health. And I imagine people get, you know, mental health first aid and QPR training, but how about being trained in that one conversation that can actually help somebody feel a little bit better? And so we're going to help get teachers, coaches, you know, counselors trained in single session consultation so they can have better, more meaningful conversations in the school building. Again, I'm not training them to be therapists, but what we're doing is they're having these conversations anyway. So let's help them have the best possible conversation they can have, and so that way everybody feels a bit more competent when they're doing that. Jacqueline, yes, 100%. I think getting CHWs trained in this would be, I think that'd be number one. I think love it. That should happen tomorrow. And then number two, obviously, it would be cool. Like if the University of Alaska Anchorage or somebody else it'd be great to follow like the outcomes too, just to keep, because I mean, the more research we can publish that demonstrates the utility. I mean, we know this intervention works, but right, we still down the road, we want payers like Medicare, Medicaid, others to pay for these things. Like they should be paying for CHWs to deliver this, right? So that's the reason for a lot of it, to keep publishing when we can.
Thank you. There's another question in the chat. What makes a qualified professional?
Sure. So again, honestly, I would say like somebody like a CHW, you know, a lot of it like for example, there's an unlicensed school counselor, a coach. So people who already have some level of training in terms of some of these basic kind of human interactions, right? So for example, hopefully, right, teachers, school staff they're getting continuing education in terms of how to handle certain situations in schools. So these are people who would be having these conversations anyway, right? So again, also going to Jacqueline's example of CHWs. CHWs could be having these conversations anyway. So we can either train them to have the optimal one conversation or let them wing it. So let's not let them wing it, right? And again, consider these kind of consultation or coaching sessions rather than therapeutic interventions. And what I know I'm walking a fine line here, and there's a reason for that. The goal for this is not to cure depression or cure anxiety. The goal for this is to reduce the stress and improve functioning. That's it. We're not diagnosing depression. We're not diagnosing anxiety. We're not diagnosing anything. All we know is that somebody's coming to you in some level of distress, which is impairing their ability to function fully. So let's help them. Let's lower distress, improve functioning. And if that helps, great. If it doesn't, then you send them people like us, and we'll help with the diagnostics, right? Get more into it. But because the other thing is, you can imagine, right? If you start you're saying that you're doing a depression treatment, now the FDA gets involved. Now you got to think about diagnosis, but you don't really need that. Like that's not necessary. And this is what Dr. Schleider has proven. You don't need to lower distress and improve functioning. You don't need a whole diagnostic workup. There are certain basic elements of a coaching intervention like this that will actually move the needle on lowering distress and improving functioning.
Wow. I just am so pleased and excited about the connections that are being made here. There's some really great suggestions for connections being made in the chat, including to community health workers, but also to the Alaska Training Cooperative. These are all really great follow-ups that we can certainly help facilitate. I also want to just give a shout out to Jacqueline Summers. She's our director of the Alaska Health Workforce Coalition here at the Alaska Workforce Alliance. And please, you know, if anybody else on the call that your wheels are turning, please do reach out directly to Jacqueline. That's what she does. She makes those connections. We'll just keep having this conversation. What a hopeful presentation this has been. Thank you so much, Dr. Arzubi, for your part of the presentation. Dr. Arzubi said the number one thing he wanted us to walk away here knowing is that the most common number of behavioral health visits nationally is what? People, put it in the chat. One, and that intervention that's designed for that one visit, being able to really improve outcomes, prevent suicide. How can we not think about using our resources more wisely here and getting people the care they need? Let's follow up on this. I've had some direct messages here in the chat as well for some future ideas. Just really excited for how we can take this energy and maybe some more steps, some more next steps. Yes, huge for the vets. Louise, thank you for that.
Mariko.
Yes.
Oh, sorry, I apologize. I forget the exact dates. Maybe Christy, you know, but the Alaska Mental Health Trust has a big annual meeting, a lot of behavioral health stuff. I'll be there giving a talk. If you're sick of me already, then don't bother. But if you want to, and you don't need to show up for the talk, but if you want to stop by and say hi and you want to talk further about this, Christy and I will be there. But it'd be great to meet people in person too. We're up in Alaska a lot, and we have now somebody on the ground too as well. So again, we're trying to do our best. The similar challenge we have in Montana, Idaho, Alaska. Those are the problems we're trying to tackle, and would love to stay connected with everyone.
Thank you. And Jacqueline's put the Improving Lives Conference link in the chat. It looks like it's September 17th and 18th. Jacqueline also put a link to a couple of other links, the sanluca.ai link that Dr. Arzubi referenced in the chat, so you can check that out as well. We are nearing the end of our session, so just want to say thank you so much to our outstanding presenters. We'll, just if independently, if you want follow up, again, please follow up with myself or with Jacqueline or Taylor. We're gonna wrap up this section, and just a quick reminder that our June 10th BEC meeting will be about opportunities in the construction sector, by the numbers, featuring ICER and Alaska General Contractors Association. And again, just a reminder that we will not be meeting in July. And with that, just want to thank everyone for this engaged conversation, and have a wonderful and safe May. Bye, everyone.